Welcome everyone out there, and thank you for all the work you do to support your communities. My name is Daniel Lanford. I'm at the Georgia Health Policy Center in the Andrew Young School of Policy Studies at Georgia State University. What brings me here today is my fascination with health and social service collaboration. As a researcher, evaluator, and consultant, I see a lot of people working hard to address health-related social needs as part of their efforts to improve health and health equity. A key question in that work is how to bring together all the needed partners, including people from large institutions and people from the communities at the heart of the work. I'm joined today by Liza Creel and Natalie Pasquenza, two people who have been right in the middle of this work. Liza and Natalie, you've been involved in a number of interesting projects. You recently had a very interesting study published in the journal Health Services Research that looked at programs for pregnant and parenting women with substance use disorder, and you compared locations in rural, urban contexts. Tell me a little bit about this work and how you became involved in this work.
Sure. Thanks, Daniel, and thanks everybody for joining today. So my research really focuses on health policy and how really the infrastructure that we build in healthcare systems facilitates better access to care and better quality of care. So I'm really interested in how local systems of care work together to really improve community and family well-being.
Sure. Thank you, Daniel. This is wonderful to be here today. So I am a pediatric nurse by trade, and so I worked at the University of Louisville for years in pediatric research. I started off in vaccine research and then moved over to health services research, which is where I met Liza and the work that she does there.
Yeah, so I should have mentioned what I do, not just what I'm interested in, but I'm a health services researcher by training, and used to be previously at the University of Louisville in the School of Public Health there. I'm now at the University of Colorado at the Anschutz Medical Campus, but maintain a really strong research collaboration with some colleagues back in Kentucky, many of whom worked with us on this study. So back in 2019, there was a grant opportunity that was released from the Robert Wood Johnson Foundation as part of the Aligning Systems for Health program. And this is obviously a program that is also coordinated by the Georgia Health Policy Center, and how we got connected with you, Daniel. One of the members of our research team is Dr. Scott Duncan. He is a neonatologist who also serves on the board of Volunteers of America Mid-States. And at the time this grant opportunity was released, Scott came to a few of us who have been collaborating around some Medicaid policy research and some other really interesting research questions. And Scott said, I think there's an opportunity to really consider how systems of care facilitate and support pregnant and parenting women who are seeking or in recovery for substance use disorder. And I'm aware of this program called Freedom House that Volunteers of America Mid-States operates that might be the perfect setting for us to start empirically measuring and understanding local systems of care. And by the way, we have this really great opportunity to look at those systems in both an urban and a rural context. So we designed a study that essentially looked at the system of care surrounding Freedom House, which is a residential substance use disorder treatment program specifically for pregnant and parenting women in recovery. It also serves their children. So their children are able to live with them at Freedom House. This program had been around in Louisville, Kentucky for many years at the time, and had recently expanded to Manchester, Kentucky, which is in the eastern part of the state. Let me provide a little bit of context. Louisville, Kentucky is kind of an urban center in the state. It's more diverse, and it's certainly much larger. Manchester, Kentucky is in Clay County, Kentucky. This is in rural eastern Appalachia, and is a much smaller community where people have to travel further for services and supports. When Scott brought this idea to us, I sort of fell in love with it. I thought this is exactly what we want to be doing. We want to try and understand where are their strengths and local community assets that we can really build on through policy making, through local decision making, to try and improve care for pregnant and parenting women in recovery and for all people who live in communities. So we loved this idea. And as you know, Daniel, but maybe others who are listening today don't, the framework for aligning systems which is part of this aligning system, was developed really out of this Aligning Systems for Health program, really lays out the ways in which organizations in healthcare, in public health, and in the social services sectors can work together or align around many things, around their shared purpose, around data, around financing, a very critically important health policy question, and around governance to improve both individual and community health. So using that framework to understand how local community organizations across sectors were working together to support pregnant and parenting women is exactly what we needed to answer this question that we had sort of had in the back of our minds for a long time. The other thing it did was it really helped us consider multiple and diverse needs and how systems of care may vary in both rural and urban contexts. So all of that is to say that is how the SHERO study was born or launched, to measure and compare overall and cross-sector alignment. And I should just mention, by the way, that SHERO stands for Strengthening Health Equity and Recovery Outcomes, and we think really is a nod to the strength and courage of the many women seeking or in recovery.
Thanks, Liza. So there's a lot going on here. This is complex work, both the collaborative element and learning about it so you can share what's being learned with other people who would want to do something similar. Can you talk about some of the challenges that you had to address while you were doing this work?
Sure, I could start that off if that's okay.
Sure.
So one of the biggest challenges, I'm going to put COVID aside for a minute, because at Manchester, our Manchester program actually opened in 2020. So what we didn't have immediately was the network to study, but that network quickly developed. We had already had a recovery program in Manchester, a recovery community center. So Volunteers of America Mid-States was already part of the community. But again, and then throw COVID in the mix, because we opened up that Freedom House in Manchester in March of 2020. So that certainly was a challenge and it made us think a little bit differently about how we were going to do this project, for sure.
So there was certainly operational challenges that Volunteers of America Mid-States had in sort of launching this new program in the context of a pandemic, and there were real research operations challenges. We received notice of this grant award in April of 2020. So we had designed an entire program with a lot of community engagement where we actually planned to go sit in front of people and talk to them. And it became very clear very quickly in April of 2020 that both COVID and the related cautionary restrictions were really going to challenge the rollout of this grant. And it did. We had thankfully built in a really good planning phase of this program, which helped us out a lot. And so we weren't delayed too far past our original plans, and we're able to actually launch data collection about 8 months into the study compared to 6 that we had hoped. What we did is really work with the VOA team, which eventually Natalie moved from University of Louisville over to Volunteers of America. We also had a team, a research team at VOA that was on our IRB. They were very engaged in community-based recruitment for us and in really helping us understand who the right partners to talk to were. So the VOA team helped us build a list of partners and identified someone at each organization that could really speak to that organization's collaboration with other local partners. For this study, we conducted in-depth interviews with representatives of healthcare, public health, and social service organizations, asking them about their connections with Volunteers of America and Freedom House, and also their connections with each other, so that we could really essentially map out what this network of organizations serving pregnant and parenting women and a lot of other people really looked like, where there were structures and systems in place to serve the community. So we asked them about how they work together or partner around those 4 areas I mentioned: shared purpose, data, financing, and governance. And this was kind of tough. These were not short interviews. We asked about 2 time periods in this, People were very committed to giving us all of the information that they were able to, while also really trying to support their clients in the midst of a pandemic. So recruitment and data collection took a while.
I do want to step in here and say that Liza mentioned this, but the initial interviews were 2 to 2.5 hours long initially. And I love the fact that our partners gave us that time. I think that just shows the dedication of our partners and the trust they have in Volunteers of America and the trust that they have in the research that we're doing with our research partners. So that was just amazing. I was thinking about it the other day and I was like, they really did 2 hours. They sat and were so engaged and recognized the importance of this work that they gave us that time, which was amazing.
Well, Natalie, y'all put a lot into this. Other people put a lot into this. There were a lot of people putting a lot into this. What are the key things that you're taking away from this work and that the listeners should be taking away from this work?
So, from the Volunteers of America Mid-State side, for sure, it's helped us understand that, give us a better idea that communities are built differently, and we are expanding our Freedom House work to a couple different areas of the Commonwealth. And while our history and how we come to communities is that we're invited, right? We don't try to parachute in and tell people how to do their work. It's just made us think about how the communities are organized. In one area, we have actually in two different areas, we have pretty substantial healthcare partners and like hospital systems that are there. But in another one, which is in Stanford, Kentucky, we don't. So trying to think about how to find those partners and how those partners might interact with us, and learning who the other partners are has become much more important than it was before.
So I'll build on that from sort of what are our key research findings that I think are really relevant to local systems of care, particularly those engaging healthcare organizations. The main takeaway is that systems of care in rural and urban communities are different. But let me be clear, that does not mean they do not exist in places. They may just be more or less formalized in different ways in different communities. And that's largely because communities are building systems and networks based on the assets that are already there. So although our research really if you look at our data overall, the two communities in terms of collaboration kind of looks similar, right? About 50% of the organizations are working together in some way. But when you start diving into the structure of those collaborations and partnerships and the ways in which sectors align across the sector, right? Public health working with social services, healthcare working with social services, that's where we start to see some variation. So the rural community, this is Clay County, Eastern Clay County, Kentucky, the rural community really built on more informal types of relationships, doing work together because their missions were aligned, governing together because many people already serve on each other's boards or they're already on a community decision-making group together. We don't see large data sharing platforms there, for example. In fact, one participant told me, we don't really need that because we see each other every morning at breakfast. Those informal partnerships are a strength of this rural community. The urban community has a system or network that was able to leverage more formal partnerships, building data sharing systems, establishing shared financing strategies, both of which require really more legal agreements and formalized structures. This infrastructure is really a strength of this urban Louisville, Jefferson County community. We also find that public health and social services organizations play a more central role in the urban community. One area where we didn't observe as much alignment in urban Jefferson County was around shared purpose. And this sort of stumped us for a little bit. We thought that's just really odd because everybody's very mission driven. But we actually think this might be because there's more duplication of services in an urban setting, and that those organizations may actually be competing against each other for both clients and for resources instead of building collaborations together. So they're using their mission statements to really differentiate themselves in the market because they need to stay financially sustainable. We also found, and I think this may be particularly interesting to the listeners of this podcast, that in the rural community, the healthcare sector and the local hospital specifically played a very important role. In fact, if you were to draw a map of that network of organizations serving pregnant and parenting women, the hospital sits right at the center of this network. This was particularly true when we look at the role of the local hospital in disseminating both information and resources to other organizations. What this tells us is that, at least in this rural community, and I will venture to say this is likely true in many rural communities, the local hospital connects other organizations together. So when two organizations may not be directly tied together, but they're both tied to the hospital, they build an indirect tie to each other that can strengthen the network. It ties them together in a way that may improve care and may improve non-medical supports for local residents. If we kind of logically extend this to this phenomenon, if you will, to the conversation about rural hospital closures, we can consider what might happen if a rural hospital were to close. Our data demonstrate that, at least in this rural community, this community is more dependent on the healthcare sector. Therefore, a rural hospital closure may lead to loss of both healthcare services, but also loss of those connections between other critically important organizations.
Well, let's move on to the next question. What are some ways, we're thinking about the community here, the communities involved, the people with lived experience that we're doing all this for. What are some of the ways you've been able to leverage their strengths and assets to make this work successful?
Absolutely. So I can talk about the two staff members from Volunteers of America Mid-States that participated in this project with us. And their role was to, in the two different areas, to recruit current clients to help us understand what community partners they received services from, which ones they wanted, or what services they needed and couldn't find. And so that helped us. That's helped us with our to find out who we needed to actually discuss and interview those partners. And they were amazing. So much so that same type of concept we are continuing on in another project that we're doing for a longitudinal study. In fact, one is the exact same person. So we love how they have been able to become part of our program evaluation that we're also doing. So that's how we incorporated those into this work.
I will add that we have shared this work extensively, and not just in the academic literature, although that's been fun too. But sharing this to local community leaders, the health system leader, for example, leaders of the local health system in Clay County, we shared this with elected officials to say, there are real strengths here that you can leverage, but the strengths in an urban community may look different than the strengths that will really lead to success in a rural community. And being able to sort of use this research to engage people around decision making and how to consider funding opportunities or other things in the context of those community assets and strengths has been super fun.
All right, Natalie, I'm going to pitch this last one to you, and Liza, maybe you can follow up if you've got anything to add. What have you learned in this work that might help health system leaders, clinicians, researchers, and others better understand how to partner with people in this community or the organizations that surround this community? How do you build those partnerships?
Again, just actually understanding that the community network and how each organization might interact with each other is very different. And you do need to take a step back and look at it rather than just assuming that everybody collaborates and all is good. Not that all isn't good, but again, how they're interacting with each other and where you fit and how you can fit into that network. And understanding that is probably going to be key to the success of whatever programming you happen to be bringing in. And another thing is not something that we've also learned. We have our strengths and we can do what we do, but we don't have to do everything. And it is really important to, again, understand the networks that are there and what programs are already in place, who's already trusted partners, so that the work that you do is welcomed and just becomes part of the community.
Yeah, I'll just add, I think one of the things that really excited me the most about this work and why I really love sharing it is that we really demonstrate that in each of these communities, both rural and urban, both need partnerships, right? To Natalie's point, to adequately, sufficiently, comprehensively serve their clients, pregnant and parenting women in recovery, or many others in need of healthcare, public health, and social services. Understanding those networks, right, and those systems, including who sits at the center of them and who holds powerful roles in these networks and of collaboration, can be really, really important. And it's going to depend on the community itself. And I think this has two kind of main implications. First, understanding the local system of care when Volunteers of America considers an expansion into a different part of the state, and how the organizations within that community collaborate can better inform how VOA or other organizations can come in and say, we're here to strengthen things, not to disrupt them, right? So it sort of builds on existing collaboration, but minimizes resource utilization and potentially improves outcomes. And I think the other piece that I sort of alluded to earlier is that our findings and really this really strong collaboration where we've all bought into this meaning something, and this going forward as a way to inform how we invest in communities to build systems of care. I think our findings really suggest that we should encourage flexibility in policymaking, flexibility in other types of decision making to really build on the strengths of local systems of care and allow for innovation in design of local and regional interventions.
Liza and Natalie, this is fascinating work. This has been a magnificent study, and I'm so glad you're out there doing this work. We look forward to hearing more in the future. Thank you for being here today.
Thank you.
Thank you.